So for our final case for the day, the patient is a 69-year-old female with a history of hypertension and prior stroke who presented to a local hospital with postprandial nausea and vomiting. An EGD showed a duodenal stricture. Biopsies of the stricture demonstrated reactive changes only with no malignancy identified. She has since been transferred to our campus for further evaluation of this duodenal stricture.
Okay, so just a few more details for the case. In addition to the nausea and vomiting, which was going on for about 3 weeks, the patient had about 15 pounds weight loss as well. A CT was done in addition to the EGD at outside hospital. The patient has renal insufficiency with creatinine of about 4, though, so the non-contrast CT was really unrevealing. At the time of the outside endoscopy, they removed about 1.2 liters of fluid. We're just suctioning here, so again, we have a lot of retained fluid. What are we at there? About 2 liters now. Looking down into the duodenum at the level of the stricture, things do look pretty bland in terms of what we can see so far. So some fluid retained in the duodenum itself. And then just looking underwater, trying to see this picture itself. So really, tough to see any kind of lumen here. I think we'll have to do some more diagnostics. We'll briefly switch to the XP scope and see if it goes through. I think it's going to be too floppy to really advance through something this tight. Making a little progress here, actually.
Almost looks vaguely extrinsic or something.
Yeah.
Non-imaging, they didn't see masses in the pancreas or
no mass, but again, the imaging is fairly limited by the non-contrast study. So if we can't, go through this picture, and I expect even if we make it through, it'll look pretty bland. We'll switch to EUS and kind of assess what's going on first, and then decide what kind of therapy would be appropriate for this stricture. Yeah.
Do you have any history of NSAIDs or anything like that? Not that this really looks like that, but anything to explain the picture here?
She is on daily aspirin at home, no other NSAID use. It sounds like not much in terms of like postprandial pain in the past. Okay, so we'll switch to the XP scope now. Oops.
So yeah, it certainly seems like something malignant. I think we're dealing with it. It's suspicious. There's nothing obvious, nothing that we can see. So I think EUS is probably going to hopefully tell us a lot when we get down there.
Yeah, and what we're seeing on EOS in terms of mass, we can assess resectability and kind of help that dictate what kind of stent we're going to place. Certainly, if he's got a history of stroke, hypertension, with renal insufficiency, she may not be the best surgical candidate regardless, but if we see something clearly unresectable, I think that, of course, pushes to doing gastro-enterostomy rather than stenting.
So now, did you consent her for gastro-enterostomy? Is that something you were thinking of?
Yeah, we consented, thinking of the gamut of basically benign septic stricture versus extrinsic malignancy, or even intrinsic malignancy. We consented for the whole gamut, so dilation, enteral stenting, or EOS-guided GJ. Okay, could I have the water hooked up to this?
Yeah, one nice advantage I will say about EUS GJ potentially in this case is, let's say we wanted for obstruction, but we wanted to put in an enteral stent. We're going to put anything without a tissue diagnosis. We're going to have to put it fully covered. That has all kinds of issues with migration. Do we suture it in? Are we going to block off the ampulla? But in theory, if we want to go ahead and just do an EUS GJ, even in benign disease, we potentially can do that. And worst case, it's something benign and reversible, which I
Kind
kind of
of
doubt.
a
But
PD
if it
biopsy
is,
forceps.
I don't think we've burned any bridges. We could always just take it out later.
So even with the XP scope, I'm sort of just hitting the stricture and then looping in the stomach and forcing me back. The one thing I think we'll all try sometimes is just passing something down the scope channel to stiffen it. So we'll pass the PD biopsy forceps briefly and try it, and then I think we'll switch to the US. Okay. So that did actually help us get through. But again, not much to see down here. So as Chris mentioned, it sounds like extrinsic stricturing, and certainly the concern would be some type of mass. I mean, she certainly doesn't have a history that would raise concern for any kind of acute or chronic pancreatitis where we would expect an inflammatory mass to be causing stricturing. So let's switch to the EUS now. All right, so now we're in the duodenal bulb here. Adjust the setting. We have the gallbladder. Making sure it's not artifacts shadowing down there to the right, but potentially here's actually the head of the pancreas. Not seeing much of a mass, actually. And jumping out to you, Chris, here.
It's starting to look a little hypoechoic here. Let's see what the ducts do.
Looks like they taper pretty well at the duodenal wall. Okay, so we still have the pancreatic duct here. Yeah. A little bit of dilation there. Yeah.
Yeah, it's looking a little big.
This
Looks
portion
a little
here.
kind of hypoechoic in the area.
Yeah. Okay. And then, yeah.
See how it looks.
Don't think the scope is gonna get through. But yeah, definitely here it's starting to be a little bit more concerning for a mass. The vasculature I think that we can see though is fairly well respected. So I have my confluence there. Okay. So I think we'll start basically with FNA. So can we call histology? We'll sample this area here. Pancreas head. Let's go ahead with the acquire. I guess we'll get a healthy sample here. Yeah, so this is more concerning down here. Although again, not seeing that much duct dilation or duct obstruction. We'll come back and look in the body of the pancreas, see how the parenchyma up there looks. So here I'm at the liver, tracing the portal vein out to the confluence. And then I have the pancreas here, the body. Actually at the left adrenal gland there. Does seem atrophic even for her age. Okay. Just for orientation, here's the PD and the pancreas neck. Yeah, not significant dilation, not here. And following the tail out to the spleen there. So while we're waiting for pathology, we'll just scan around, I think, for lymph nodes, or any metastases, or anything else that would give us more information.
All right, so this is Chris Hammersky here. I'm with our pathologist, Dr. Chris Soon, who's going to tell us what we found on the fine needle biopsy.
Okay. So I took a little bit of the sample and made a smear here, air dried, and it just took like a minute for me to make. And you can see this is a good sample with these malignant looking cells here. And the criteria I use are, are these, so benign epithelium should be very ordered and honeycomb looking. Right here you can see there's like they're disordered. They have a range in nuclear size, irregular contours, and so this is adenocarcinoma. And here's the point. Usually, where I ask Dr. Hammersky, can you take me another sample for cell block, please? Although we do think that the smear is adequate for the diagnosis. So.
The oxygen, I think, extending into the mesentery, pretty sizable. Not only that, while the portal vein and the SMV, next to the head of the pancreas look well respected. This is just for reference, the SMV, the confluence, portal vein here. And actually, as you trace the SMV down, you can see what looks like basically the secondary branches coming off and heading towards the mass and getting basically encased. So it's small, but we have, I think, vessel here as an SMV secondary branch. Yeah, there you can see it nicely connecting to the SMV, that thinner vessel, and then being encased by the mass itself. So certainly when we have deeper mesenteric involvement like that with secondary branch encasement, that becomes very difficult for any kind of surgical removal. So I think that we can safely say up front, this is not going to be something that would be addressed surgically, in which case the preferential method of treatment for the stenosis is going to be gastro-enterostomy. So the final thing that I do just want to look at is the right lobe here. For staging, didn't see any mets on the left lobe. I see, scattered shadowing, some irregular geographic distribution within the liver, but no clear metastases here.
And I think that's a good point too. You're saying that, if you have SMV involvement itself, that doesn't necessarily preclude the surgical option. But once you start seeing the secondary branches, then I think it's off the table, right?
Right. Okay. Okay. So now we're gonna change back. We'll reintroduce the therapeutic gastroscope so we can advance the guide wire across the picture, and then the ENDB or EMBD drain basically for water infusion into the jejunum. Tarun and Chris last night, for those that were at the AXIOS symposium, and it sounds like their standard is the 20 millimeter. So far, I would say actually we've had the 15 millimeter place. We always consider the option for upsizing if patients become symptomatic or if they have only partial symptomatic relief. And I think there are few, if any, patients that have needed to come back for upsizing to the 20 millimeter AXIOS. Thanks. So we put our guide wire through the stricture, injected. It looks like it's about 3 to 4 centimeters in length. The second portion of the duodenum, downstream in the third, and for a loop or two beyond that. no additional stitches were noted. You can see here on the EUS, I do have my nasobiliary catheter that's visible right within the lumen. On the fluoro, you can see that the catheter probably is placed a little bit more distally within this. And that's fine. I mean, we could pull it back so that we're actually targeting closer to the pigtail, but I can see the drain nicely. I think this is a good target here. So, yeah, so please show the EUS. Yeah, that's broadcasting. Okay, so we'll take the AXIOS now, the 15 millimeter AXIOS. So essentially this whole time I'm just continuing water infusion to keep things inflated. So far I think we're in fairly stable position. Of course, once you put the axis down, it sometimes changes your lineup or orientation.
I was gonna say, Andrew, your view makes mine look terrible. Oh, mine was perfect. Great.
Don't jinx me, Revenger here.
Nobody move.
Yep, so I'll have the cautery pedal. Could you actually, here, I'll switch seat. Okay, so I'm making sure the device is locked on tightly to the scope. I'm going to unlock the catheter, advancing here just to 10, so probably the same settings that have been used in the other cases, but we're on 100 watts, effect 7. Still stable position here. Okay. And Jeannie is being kind enough to stabilize the scope for me. Okay, I'm going to punch it down. Okay. So we still have good visualization of the catheter within the jejunal loop now. So I'm locking the catheter in position here. Okay. Snapping off the safety device. Try not to hit the nurse in the face with it. Deploying the distal flange. Okay, unlocking the catheter. We're going to hub things here. Again, until we have some distortion. So I think that looks good there. And can I have an endo view on one of my screens?
You want it now or you want it
Now? Okay, and let's actually show them the endo view also.
endo big? Okay.
Okay, so I'm deploying the proximal flange within the scope now. Okay, can I have one EOS view though?
What EUS?
Keep one EOS on one monitor, please. Okay, and you guys see the end of view, so then I'm pushing out, wheeling away, deploying the proximal flange out of the scope. Okay. All right. So we'll have the wire through now. Okay.
Anything that can go wrong here, Andrew?
I think that at this point, I mean, the things to be concerned about are essentially bleeding when we do the dilation, which can cause some immediate bleeding. Of course, we have the stent in place to tamp it on. And then just being careful not to be too aggressive with movements at this point and dislodging the stent.
Wire spool.
Okay. So we'll just look for the wire on fluoro. Good. Looks like it's looping into the jejunum nice. Okay, and let's put the endo back up. Okay, exchange. Okay, hold on. All right. Okay, keep exchanging. All right, I'll have the 12 to 15 CRE. I don't always necessarily dilate immediately. I don't know about you, Ravindra. In particular, if I can see, of course, the fluid is reassuring. I think we actually have a pretty good EUS view of the distal flange still in a loop of bowel. The other thing is sometimes you can just see the nasobiliary drain through the AXIOS stent lumen without dilation. I think I caught a glimpse of it, but it will just dilate. So.
I think they're all good tools. I think Druin had alluded to putting in methylene blue to see that come back. You know, you see the blue, it's good. You still have your EUS blue too, and I think that's very helpful. Especially now that you have the fluid coming back, you actually have a good acoustic coupling too. I can see it pretty well. And then of course fluoroscopy is your other crunch as well.
Okay. So we can go ahead and dilate to 12.
Moving up now. Maybe,
Okay.
maybe not. One moment. Okay. Try it again. Dilating up now. Is it up? I can't even.
Yep.
Oh,
So balloons up,
that's 12.
and you fight there. You can go to 13 and a half.
13 and a half is up.
And go to 15.
15 is up. You want me to just go up and
Okay,
down?
and you can see a final fluoroscopic view. We're not going to go through this at all, so you can come down right away. Okay, and there we see nice jejunal lumen, jejunal folds, and you can see the nasobiliary drain, the blue there. Can we switch to the full endo just for this one shot? You can see the nasobiliary drain there.
That's it.
All right.
Nice job, Andrew.
Yeah, so we can pull everything. I think that's the end. We'll go back to the auditorium.
I think
Dr. Bimler is done, right?
I think everything's done. I think we're
Bring it
all.
home.
Okay, well, thanks for joining us for the day. Thank you to those who stuck it out till the bitter end here. It was fun on this end. I hope it was enjoyable and educational for everyone. Yeah, so we're going to be, I think if there are any last minute questions, we're happy to answer something here. Otherwise, of course, we look forward to the discussion tomorrow and hope we get a chance to see and catch up or meet everybody that was here today. Chris, Rabindra, any comments?
Yeah, no, we just want to definitely thank our nursing staff. It's been a long week on them, and I know they've worked very hard, and so we definitely want to express our gratitude to them and everyone who made this conference possible. And obviously, we'll have some more fun tomorrow and kind of do some good wrap up. And looking forward to a good discussion tomorrow.
Very good.
All right.
All right.
Thanks.
Hey, guys.